Welcome, folks. Dr. Charles Parker. I'm here to tell you about one of the most important clinical problems that we see almost every day in my outpatient offices. And we've been seeing them since the early 90s, and we've been talking about it for many, many years. And it's this following problem regarding missed diagnosis and mistreatment of comorbid attention deficit disorder and depression. So I call it the basal ganglion seesaw. If a person has depression and ADD at the same time, and one of those halves is missed, it makes the whole problem much worse. And the person feels completely untreatable, like a treatment failure. If you feel like you're a treatment failure, you've been treated and treated and treated for depression, but it's not getting better, it could be that you have a significant attention deficit disorder problem associated with it. So how does the seesaw work? Well, it's really simple. On this side of the equation, the seesaw is a balance like a regular seesaw, and you got attention deficit disorder on this side and depression on this side. Okay, so attention deficit disorder has people have a problem with dopamine deficiency. I'm oversimplifying it, but let's just call it a relative dopamine deficiency, and we're going to treat that dopamine deficiency with a dopaminergic medication, something that's going to affect the dopamine function on that side of the equation. And a person who has depression, many forms of depression, predominantly serotonergically related. So you're going to use a serotonin medication for depression. Now, if you miss one of those halves, here's what happens. So assume that a person has both problems going on, but one half of it's not recognized. So what happens is a smart pediatrician comes in and sees this child with attention deficit disorder, treats the dopamine side of the equation and pulls that dopamine up appropriately. What happens to the serotonin? It actually goes down. Well, what happens when serotonin, which is already compromised, goes down? Well, the child feels like they're completely depressed. They crash very hard in the afternoon, vigorously. And what happens then, the individual, most of the time the physician will try to change the dopamine product repeatedly and miss this side of the equation. Pediatricians are not trained on the depression side. Some of them are not trained on the attention deficit disorder side, but that's how the oversight occurs. Now, if you take the other side of the equation, what happens frequently with adult psychiatrists, not all of them, and this is not all pediatricians, but this is what happens. An individual who sees only part of it, say an adult psychiatrist sees only the depression, they get the serotonin correct, but they aren't really trained to recognize attention deficit problems. In fact, many of them just don't believe in attention deficit disorder, which is a whole other thing. So what happens is you get the serotonin treated, you get the dopamine come down. What happens when a person loses their executive function? You tell me. Bipolar illness. Yeah, it's not bipolar. It is half of the diagnosis is missed. You can't treat a serotonergically related problem, a depression, with a dopamine, nor can you treat a dopamine problem with serotonin. Serotonin doesn't treat a dopamine problem. Dopamine doesn't treat a serotonin problem. So you have to treat both of the problems simultaneously. It's just like if you came in and you had heart disease, and I were a physician, I said, listen, I know you got heart disease, but I'm going to try and treat it with insulin. I'm going to give you some diabetic medication, and I'm going to cross my fingers and hope that it works for a heart disease. I don't think so. So what happens is we have two different disease states, really, for want of a better expression. One of them is dopaminergically related, one of them is serotonergically related, and we have to treat each one simultaneously, carefully, with very clear ideas of what we're doing on both sides of the equation. Very simple, very quick. Think about this. Don't treat depression with a stimulant. Don't treat ADD with a serotonergic antidepressant. It will not work. The person will get worse, and they will very likely be called, you guessed it, bipolar illness, and get a big dose of Depakote, which they don't deserve. So thanks for your attention. Talk to you later. Have a good one.
According to the latest from the CDC, the rates of all of our top 10 killers have fallen or stabilized except for one: suicide. Accumulating evidence indicates that oxidative free radicals may play important roles in the development of various neuropsychiatric disorders, including major depression. For example, in a study of nearly 300,000 Canadians, greater fruit and vegetable consumption was associated with lower odds of depression, psychological distress, self-reported mood and anxiety disorders, and poor perceived mental health. They conclude that since a healthy diet comprised of a high intake of fruits and vegetables is rich in antioxidants, it may consequently dampen the detrimental effects of oxidative stress on mental health. But that was just based on asking how many fruits and veggies people ate. If you measure the levels of carotenoid phytonutrients in nearly 2,000 people across the country, a higher total blood carotenoid level was associated with a lower likelihood of elevated depressive symptoms. And there appeared to be a dose-response relationship, meaning the higher the levels, the better people felt. Lycopene, the red pigment predominantly found in tomatoes, but also present in watermelon, pink grapefruit, guava, papaya, is the most powerful antioxidant among the carotenoid family. In a test tube, it's about 100 times more effective at quenching these free radicals than vitamin E, for example. And in a study of about 1,000 older men and women, those who ate the most tomato products had about half the odds of depression. The researchers conclude that a tomato-rich diet may have a beneficial effect on the prevention of depressive symptoms. Higher intake of fruits and vegetables has been found to lead to a lower risk of developing depression. But if it's the antioxidants, can't we just take an antioxidant pill? No, only food sources of antioxidants were protectively associated with depression, not antioxidants from dietary supplements. Although plant foods and food-derived phytochemicals have been associated with health benefits, antioxidants from dietary supplements appear to be less beneficial, and may in fact be detrimental to health. This may indicate that the form and delivery of the antioxidants are important. Alternately, the observed association may be due not to antioxidants at all, but rather to other dietary factors such as folate that also occur in fruit, vegetables, and plant-rich diets. In a study of thousands of middle-aged office workers, eating lots of processed food was found to be a risk factor for at least mild to moderate depression 5 years later, whereas a whole food pattern was found to be protective. Yes, it could be because of the high content of antioxidants in fruits and vegetables, but could also be the folate in greens and beans, as some studies have suggested an increased risk of depression in folks who may not be getting enough. Low folate levels in the blood are associated with depression. But since most of the early studies were cross-sectional, meaning a snapshot in time, we didn't know if the low folate led to depression, or the depression led to low folate. Maybe when you have the blues, you don't want to eat the greens. But since then, a number of cohort studies were published, following people over time, and low dietary intake of folate may indeed be a risk factor for severe depression, as much as a 3-fold higher risk. Note this is dietary folate intake, not folic acid supplements, so they were actually eating healthy foods. If you give people folic acid pills, they don't seem to work. This may be because folate is found in dark green leafy vegetables like spinach, whereas folic acid is the oxidized synthetic compound used in food fortification and dietary supplements because it's more shelf-stable, but may have different effects on the body, as I explored previously. These kinds of findings point to the importance of antioxidant food sources rather than dietary supplements. But there was an interesting study giving people high-dose vitamin C, also known as ascorbic acid. The vitamin C, but not placebo group, experienced a decrease in depression scores and also greater FSI. What is FSI? FSI evidently stands for penile vaginal intercourse, an acronym that makes no sense to me. But evidently, high-dose vitamin C improves mood and intercourse frequency, but only in sexual partners that don't live with one another. In the placebo group, those not living together had sex about once a week, and those living together a little higher, once every 5 days, but no big change on vitamin C. But those not living together on vitamin C every other day. The differential effect on non-cohabitants suggests that the mechanism is not a peripheral one, meaning outside of the brain, but a central one, some psychological change which motivates the person to venture forth to have intercourse. The mild antidepressant effect they found was unrelated to cohabitation or frequency, so it does not appear that the depression scores improved just because of the improved FSI.